There we go. Hi, everybody. It's Kevin and it's Donna, and welcome to another episode of the Med List. So excited to have you guys here. And Donna, we've had a real Canadian flavor over these last couple weeks, and I've really enjoyed conversing with our brethren from up north. I think the last conversation we had really on the deep prescribing, standpoint of things, and a real innovator in that space, and now bringing in some folks here that are doing something a lot differently, especially during this time in retail pharmacy history when we're seeing a massive dropout in number of stores across the United States. So we're just seeing more and more pharmacy deserts, that are happening. So really a thank you just to have a pharmacy, period. But these two men are really talking about an interesting new push to get the pharmacists out front.
Yeah. They've been doing it for years successfully. That's what's been amazing. And what we're unearthing it now, Kevin, but I'm glad we are.
Yeah, well, it's too much fun. And I think during this episode, please jump in, join, add questions, anything else you guys might have, and we'll play the reel and get rocking and rolling. Talk to you soon. All right, I'll pull both these guys up.
Yeah.
Go.
So excited to have two guests with us, which is always just that much more fun. But so today we have with us Chris Uzaitis, and he is the chief clinician at Adhere RX and pharmacy manager of the world-renowned How Sound Pharmacy, which he has co-owned for over 30 years. Chris and his partners were early pioneers of the Pharmacist-at-Intake workflow, which allowed for stunning results from the additional patient-facing time and for staff pharmacists, and it includes that there has been clinical evidence for better patient outcomes, as well as 300% increase in prescription count and profit over the next 3 years. So that was started in 2012, and within 3 years, you saw a 300% increase. It improved medication adherence from existing patients too. So in 2013, Jim and Chris partnered to form Adhere RX, and they measured and codified new workflow. They've helped hundreds of pharmacists across North and South America and advised professionals as far away as Australia, New Zealand, and UK. Chris has 40 years of experience in both the clinical and business side of community pharmacy. He helps pharmacy owners and corporate executives help them create and sustain their own atmospheres that compassionately and efficiently provide better care and education to both staff and pharmacists. He still sees patients every day. He oversees a state-of-the-art home facility that incorporates a combination of innovative workflow, technology, and environmental design and communication and simple patient-centered care. And welcome to you, Chris. And I'd like to spend just a quick half minute or minute about Jim. And Jim Danahy is with us, and he has been designing workflow and profit improvement processes for pharmacies for over 25 years. After delivering a keynote address for Pharmacy U, Jim was able to form a partnership a few weeks later with Chris and a group of colleagues, and they formed Adhere RX. And again, after seeing these remarkable results, the team decided to turn their insights into licensed support programs and professional training curriculum that has been used to help hundreds of pharmacists across North and South America. Thousands and thousands of pharmacists have been educated through this process. Adhere RX also collaborates with universities, industry organizations, and advises professionals in Australia, New Zealand, and UK. This team, and I just want to talk about one recent over the past year, when I believe it was Canada authorized providing first ever funding for community pharmacies to deliver a range of pharmacy services, including labs, point of care testing, and a comprehensive array of vaccines. More than 20,000 pharmacies were participating across the country. So I think that's amazing. There's so much more I could talk about, but you two have just done tremendous work in the industry of retail pharmacy. And I cannot wait to dive into and learn more about Pharmacist-at-Intakes or Pharmacist First model that just seems to be a tremendous thought process and model used in retail pharmacy for both pharmacists, all the pharmacy technicians, and the patients, and also providers that are providing prescriptions for patients as well. So can't wait to hear about this model. So I don't know who wants to start first, but if you could please let us know what you're doing, we would love it.
Thanks so much. We clearly need a good editor. But thank you, Donna. Yeah, so I, as I think I've mentioned to you before, Chris is my brother by a different mother. We've been working together now since early 2013, a year into the adventure that he and his partner at the time launched into. And Chris, you stopped me at this. Let's have especially with the things going on in the news right now, let's have a Watergate rule and break in anytime. So for me, it was a discovery. I have no authorship whatsoever for this model, but I've spent my life trying to understand when really successful clinicians are having great outcomes and they're enjoying their work, what's working and what could be transferable to others. So within a couple of weeks of having a conversation with Chris and his partner at the time, I jumped on an airplane. I'm speaking to you from the Atlantic coast of Canada. Chris and Housesound Pharmacy are on the Pacific coast. So we're just bi-coastal, both of us here, aren't we?
Yes, we are.
And I discovered this serene, quiet place that is, as you mentioned, just simply delivering better care. And I'm the analyst. What is it that's working here? So Chris let me have a look at the numbers, and eventually we became business partners in the pharmacy as well. Bought out his partner at the time and became partners in the pharmacy so that we could actually try to see what's happening clinically, what's happening financially. I just met a whole bunch of people who were not harried like most are in a family or in a community pharmacy setting, and yet this pharmacy fills 800 prescriptions a day between 9 a.m. and 5:30 p.m. They've got all of the big competitors around them, and the place is quieter than a church on a Tuesday afternoon. That was actually a quote from a large pharmaceutical executive who walked in and said, "Oh my gosh, you would never know," because the noisiest thing you hear at Housesound Pharmacy is giggling. I'm not overstating this. It's not to say that people aren't working hard. In fact, if anything, they're encountering some more serious issues than many pharmacies have the time to deliver. But what we discovered over this time was that when we looked at time and motion studies, the average Canadian and US pharmacist, according to time and motion studies, spends about 7% of their time, or 4 minutes an hour, doing tasks that require the pharmacist's license. The rest of the time could be spent on other activities. There's 56 minutes in every hour then that Chris essentially repatriated, because their model kind of looks a little bit like a hospital triage. You both have hospital experience. You know what that looks like. A simple semi-private desk. That's what I saw when I walked in. The very first person that the patient saw was the pharmacist. They had their back to the pills, facing forward using their skills. They didn't enter any data in the system. They didn't adjudicate for insurance. They didn't dispense. They didn't compound. They didn't do the final checks, and they didn't manage inventory. That's the 56 minutes. Now, we didn't discover that for some years later, but I was wondering why Chris and his team were feeling rewarded, why their prescription count was growing from existing patients, until we then later measured medication adherence was higher. They're removing the barriers to taking the appropriate therapies. And that's where the Odyssey has been. It isn't perfect. And Chris, jump in here, but the work gets harder and sometimes the holes get deeper.
Yeah.
Well, one of the things when we go and we have a chance to talk with other pharmacists and pharmacist owners, those two.
Hey, Chris, we're getting a little bit of feedback on your mic, and I'll pop it right back on in just a sec. But Chris, one thing I wanted to frame is just for the audience to be able to understand overall is this. what does a typical pharmacy look like? What do the pharmacies look like that are the antithesis of what you've built? And how are they laying out personnel? How are you encountering from a patient engagement standpoint when you come in on a typical pharmacy setup versus what do you encounter inside of your guys' pharmacy, and why is it so much different? If you can jump into that a little bit for comparison's sake.
Sure. So most pharmacies work on the premise of dispensing, you know, and, you know, which is essentially manufacturing. We're going to take things from a big bottle and we're going to put them in a little bottle. And that's essentially what pharmacists have been doing for years and years. And that's the way my career started as well, is we were there to dispense. And so many pharmacies.
Hey, Chris, sorry to interrupt you again. For some reason there, can you guys hear that really high pitched squeal on your side? On your side audio, Chris, if you can hop out and then join back in, I'll bet it'll correct it. And then I'll have Jim answer this question. As soon as you get back in, we'll pop you right on. But Jim, do you want to take that one away on just, you said
Sure.
you came into this experience and you're like, this is totally different.
So a typical Canadian pharmacy operates with the same workflow as a typical American or UK or Australian pharmacy, in the sense that there is a drop-off counter where the least qualified person, a pharmacy assistant, greets the patient, receives an incoming prescription, enters the data, and so on. And the pharmacist often is not engaged until they're checking at the very end, when it's too late to fix something or without cost or dislocation. So it then ends up with the pharmacist doing both the clinical and the therapeutic check at the same time at the end of the workflow. So that's the typical environment. And maybe I can throw back to you, Chris, so I just explained how the typical pharmacy works, and that's what most Americans, Canadians, and Brits experience. Do you want to just describe what the steps are in the flow at How Sound Pharmacy?
Well, maybe quickly I can go back to why we did this model. So part of it is back in 2011 and 2012, there was a project of introducing medication management into British Columbia pharmacies. And part of which enticed us so much is that we could actually get paid for our counseling. So that's what we had been doing for years. It wasn't under that structure of medication management, but all of a sudden we could get paid $60 for counseling with patients. Count me in, great. Let's do that. So we joined the project. And of course, there's a lot to medication management. And when I graduated, medication management was not in our curriculum at all. Medication management was more for hospital-acquired pharmacists who went on to do a specialty. So when that started and we learned the basics of medication management, it's a win-win-win for so many aspects of our patients when you sit down across from them and be able to discuss the medications. One, it was a win for me. I've already been practicing for 30 years. I found that medication management rejuvenated my career. Wow, I'm talking with people. I'm making such a difference in their lives. And it's all because now we've structured a workflow where you can talk with your patients. You're there in front of them. That's the first place they come in and see. So it was terrific. It was a win from my perspective. And it's so much more rewarding than sitting in the back and checking prescriptions and making sure the final check is correct. Now, don't get me wrong, that's important, but we now have registered technicians to do that, quite honestly. So let's get them to do it. And you know what? They do it quicker, with more accuracy than pharmacists, because we're doing 4 or 5 other things at once. So one, it was a real win for me. It was a win for the patients. They loved sitting and talking about their medications. Now, one of the things that every new pharmacist who comes into the pharmacy has to learn is, how do you stop Mrs. Smith from going on 30 minutes about her dog? And I'm sure every doctor and every nurse practitioner has all had to learn those skills, is how do you deviate away from that. However, the patients love that, and you develop a trust with the patients, which is probably one of the most important things here, is that trust allows you to be a much better clinical pharmacist.
Yeah.
Let's put the hat on a pharmacy owner, me as well. There is money to be made from billing cognitive services. It makes a huge difference. And you're talking with patients anyway. It doesn't take that much more to be efficient and clinically record your notes and make those billings to the government. Now, in Canada, a number of provinces have the similar things. The workflow is a little bit different, but we can bill for our cognitive services. So it's a win for pharmacy owners. Now, one of the things that surprises me is that my dispensing fee in Canada, in British Columbia, it's $10, which I would say 98% of the pharmacies follow. That's the fee that the government allows. Well, we actually have our dispensing fee at almost $15. So I am way off in the distance for most places. And most pharmacists will go, oh my God, you're going to cut yourself, you're going to hang yourself with that because, people aren't going to come there. Well, I tell you right now, when you give better care, people are willing to pay. They have an acute sense of value when they feel that they're getting so much more than just a prescription that's being stapled and handed to them, by the young kid who comes in after school to spend 2 hours at the till. So there are so many wins with this model that where do we start?
There's a great so Chris also he was involved in a study that followed pretty darn good random control trial. When you think about this, is 3,000 patients over 2.5 years, and while there were tens of thousands of drug therapy problems that were engaged with, they documented 4,000 of them. And the thing that was most remarkable about what the physical workflow allows when the pharmacist is not jumping up and down, right? The pharmacist is planted. They're seated. They're facing forward. They're not running to the back to manage pills. They do the therapeutic check at the very beginning and make sure that this is the right patient and the right medication. They hand it off. So if you've still got that needed 15 or 20 minute time period for a waiting patient to get their prescription, the clock starts. The data then is entered, it's adjudicated, they start dispensing. And then Chris leans in, and I've witnessed this, and says, "How are you doing, Barbara?" And at that moment, the prescription might have been for the COPD, but Barbara says, "Chris, my hip hurts." And what we discovered in this study that was done by the University of British Columbia was 47% of the documented drug therapy problems were for untreated conditions. Now, there's no possibility that could ever have been caught in an orthodox workflow where your least qualified pharmacy assistant is greeting the patient at intake, or even in many appointment-based models where we're seeing the average number of complaints is 1.1, 1.2 per visit. It's, basically it replicates a doctor's visit. They're too busy. They're too closely packed together in most cases, or they're not interested. But in many instances, unless extra time is allowed, even a pharmacist-led appointment-based model sometimes doesn't capture that either. But this relaxed environment, Chris was one of the people documenting. I've read his handwriting and seen the actual notes from those encounters. It was quite stunning.
So I have a million questions right now, but I'm really interested if we can back up for just on two things. Billing for cognitive services, is it a standard, or are you billing according to disease state or according to like symptom type thing? And is that like when you're talking to the patient doing that intake, is that one recorded cognitive service, and then that second when you're leaning in and how's things and anything else or whatever might go on, is that another billing
Right.
for cognitive services?
So things have kind of changed and evolved a little bit since 2014, when all pharmacists in the province of BC were allowed to bill for cognitive services. And so we spent 2 years trying to refine the system. And essentially, I think it was they eventually morphed it into something else, because the pharmacy software that was using to record and bill the cognitive services, Donna, was onerous at best. So it's morphed into something. So essentially what we can do is we can spend time with the patient and do what's called a best possible medication history, where if a patient is on 5 medications in the last 6 months, we can bill $60 to be able to review their medications with them. And if there is a drug therapy problem that we need to record and document, then that's a $70 encounter. Okay. When pharmacists take prescriptions that have no more refills, and there's a narrow set of criteria that we have to fill, we can bill $10 for refilling a prescription. And but if, like anything else, that the documentation has to be complete as we do that. So there's a number of different services, from providing immunizations that we can bill for. So having a pharmacist at intake, Donna, it's not difficult to be able to generate hundreds of dollars in a day in cognitive services, and you're sitting there, you're with the patients.
It's awesome.
It's not difficult. It just takes a workflow and a will to get pharmacists out of their comfort zone, which is behind the counter, and bring them up front.
If I can just jump there too, just to sort of broaden that perspective. So they're just as different countries have different reimbursement structures, so too do the various Canadian provinces. So if you move one province to the east from where Chris is, pharmacists have had full, completely unrestricted prescribing authorization to order tests, to act on them, to provide vaccinations, and to prescribe medications of all sorts since 2007. So in those instances, you may have multiple billable services that are assessment and prescribing, that may be administering of medications, injections, and vaccinations, and those kinds of things, for which each has a fee of sorts, both privately and publicly funded. The Canadian system resembles the US in the sense that there's both public and privately funded medications and services. I think the really important thing, though, as we're talking in this context of Pharmacist-at-Intake, is by our calculations, the richest fees generated by a Canadian pharmacy still doesn't amount to more than 10% of total revenue. It's still about the pills. And so the overwhelming upside from a financial standpoint is actually adherence. Just sit in front of your patients and do your job. Chris's pharmacy went from the world average of 48% adherence to the chronic medications that were prescribed for his patients to over 85 in that 3-year period. He's just removing the barriers to the therapies they should be taking. They were gently working with the prescribers, in some cases, to do what you do, Donna, which was de-prescribing, discovering there's no indication for these 3 drugs. Let's have better adherence to the 5 that worked. And that was worth between 10 and 20 times more than the maximum potential billable cognitive service fees. So the fees are instructive, but when you take it out of the reimbursement environment of any jurisdiction, the workflow simply allows you to it gives you that 56 minutes instead of the 4 minutes to do whatever you need to do for the patient sitting in front of you.
That's great.
And the adherence, even if you don't get paid a dime for service fees, the adherence pays for more than service fees ever could.
Yeah. So just talking a little bit, you mentioned it a bit there, Jim, but when looking at adherence versus deprescribing, even when you're billing for these cognitive services, it sounds like if you find something or unearth something that, you know what, you've been taking this for so many years, it really isn't an appropriate medicine for you because you're telling me you're falling, and we don't want you to, have a horrific fall. So we want to take this off because of X, Y, and Z kind of thing. And you go ahead and do that, or work with the providers to do such things. That sounds to me like that is just as billable as, sitting and counseling someone on how to use an inhaler.
Yeah. So anything that, Donna, that has a drug therapy problem.
Yeah.
Of which there's so many different types of drug therapy problems. So exactly. Any of those services is considered billable. But like anything else, you have to document it correctly.
Sure.
As the old saying goes, if you didn't document it, it didn't happen.
Right.
So,
wow, amazing. I love this, and I'm just scratching my head here, Kevin, going, are we missing the boat here?
Yeah, I mean, I to play some devil's advocate, I would say a lot of our colleagues in the US would say, no, we're not missing the boat. Just the opportunity isn't as ripe as we potentially are describing it, like overall. So getting into some of those issues, what have you guys done that's really been a differentiator, Chris and Jim, when it comes to this model? You can't just grab it and say, we're going to insert this in the pharmacy and all of a sudden it's going to work. It's going to be perfect. You've got to be able to have a couple curated things that work well for you. So I'm wondering from your guys' perspective, one, what are the relationships between you guys and payers to be able to understand this? You and the community or the patients you're working with and cultivating those relationships. And the last one, maybe most important, you and the hires that you're choosing, the individuals that either one, you're training, or two, you're choosing to be able to implement this model successfully.
So when we started this, we talked about when this project started, we didn't have a consulted intake. We were a regular pharmacy. We were 1,000 square foot pharmacy that was so tiny. We had no intake station. We had a till, and that was the intake station as well. That's how small it was. But the idea of that patient engagement meant that I would grab a clipboard and the required paperwork, and I would go sit in the front in a quiet spot with the patients. We also had a small counseling room about the size of a broom closet, and we would use that where it was appropriate. So if pharmacists want to engage, they don't have to spend a lot of money changing their pharmacy, which every pharmacy owner is going to pull their hair out saying, why are you doing this? No, you can start this like we did with no intake station whatsoever. All we had was the commitment to have better patient engagement and provide those services that patients needed. Patients need to be able to talk to whatever healthcare professional. And if you notice when patients come in, and I'm sure both of you have heard that, well, oh, he's such a good doctor, or she was so good, she listened. You know what? They probably prescribed Ramipul for blood pressure, which anyone could have done. However, you come out of that office so engaged with that healthcare professional and physician that you know what, they're theirs for life. So it's that engagement that's super important, and that's what patients are looking for, and they're willing to pay for if you let them.
I think the thing that really struck me is that I stumbled on another pharmacy owner in a different province. In fact, in the province of Alberta, which has had the highest scope of pharmacy practice in the world for 17 years. And we came across this other pharmacist. She said almost the same words. She's 15 years younger than us, Chris. And her name is Carleen Olekson. She is one of my heroes as well. She said almost the same words. I just want to face my patients. I just want to spend more time with my patients. And the discovery for the process geek here was there is no payer There is no payer conversation. There's no need for that. There is no regulator conversation. There is no need for that. You don't need permission from anybody. You need 2 chairs and a desk. And that's essentially what Chris did. That they didn't ask anybody's permission to give people better care. But what he discovered was that the bank account started filling up when they just did their job for more of the day.
Mm-hmm. Yeah. I'm curious. I know here in the US, and I'm assuming in Canada as well, that technology doesn't have people necessarily walking in with a prescription any longer. So has that changed how your flow works? When do you actually see the patient? If there are electronic prescriptions being sent to the pharmacy and you don't have necessarily that opportunity of the patient coming in and you facing them right at the start of that pharmacy flow.
Yeah, so COVID, of course, changed all of that, and it didn't change it for the better. When we were the beta site in British Columbia, we also the government tried to introduce e-prescribing, where the prescriptions went into a cloud, and then the patient could go to any pharmacy they want, type, give the pharmacist their name, their ID, their password, and they could download a prescription. It didn't happen. So that never went through, and that's been tried in a number of other provinces in Canada over the years. And honestly, I just don't know why they just can't make this work. It's mind-boggling. But since COVID, of course, prescriptions now are faxed in. And faxed prescriptions are only slightly more effective than carrier pigeon, to be quite honest, these days. It is horrendous because we deal with paper. So the way we deal with that, Donna, is faxes come in, and the pharmacist who's sitting at intake will get the faxes that are coming in, and they'll triage them. We'll look for things that are important, antibiotics, kids' prescriptions, those type of things. And then we'll call the patient and say, hey, we have your prescription here for and I noticed that there's a new change in this. Is there something that we can, would you like us to fill these? And they'll often say, oh, I'll need the new one filled, but the other ones can you put on file? So as Jim was saying, we do our due diligence right at the start while we have that patient with us. Mm-hmm. And then we go ahead and within a grid system, we let the next person know that the pharmacist has done their counseling, the due diligence. We've checked for interactions. We've checked that it's the appropriate drug and the appropriate strength. We've done all of that. And then it goes back and being filled. But faxes have been a step backwards, Kevin and Donna, that we still have not been able to crack effectively. Dealing with paper is just such a headache.
It was funny you raised that one too. So Chris and I and this other pharmacy owner that I mentioned, Carleen Olekson from Alberta, were giving a speech. We've given a speech at a couple of different major conferences, and we did it sort of as quickly as possible so that we could have Q&A. And we had like 45 minutes of Q&A, which turned into 2 hours of conversations afterwards, where people were asking Chris and Carleen, so how do you, and that exact question came up, and Carleen's comment with that was, so we've got the technical queue, but we contact, whether the person is sitting in front of us or I'm phoning them, they still have first contact with a pharmacist who's going to have the conversation and going to say, yes, that's in the work, and still ask, how are you doing, Barbara? Mm-hmm. And Barbara still gets the opportunity to say, my hip hurts.
Mm-hmm. Great. It's amazing. And it's nice that it's been developed that way for so long that it's probably almost an expectation of the patient too, that you've kept that flow in place, even though it's a phone call versus, we're not going to start anything until you come in. So I think that that's amazing how you're able to shift and that expectation is still there. That's
it was better, Donna, when patients could come in and hand you the prescription in front of them. And of course, a great way to start the conversation with patients is exactly that, and discuss it with them. So again, it's the quality of that engagement, and whether the engagement starts with a phone call or with the patients actually bringing in the prescriptions. Again, the pharmacist at intake is all about the quality of the engagement and how you develop that relationship. That probably supersedes anything.
Yeah.
And that quality is something Chris and his team have really cultivated with situations where they're triaging as well and saying, you know what, maybe this is something we should take into the room to the right with a door on it. And maybe this is something we could follow up on in a month's time. And he has a really significant and sophisticated appointment-based model as well as this. So patients are also heavily synchronized in his pharmacy. So that you've got the operational efficiency that buys more time and efficiency for patient care. And so, you know, they deliver. In those cases, then Chris has essentially detached the dispensing activity he was describing at the beginning of this conversation from the patient care. You're just coming in now to see Chris. We're delivering your pills on a different date. There is no reason why the frequency with which you have contact with Chris needs to follow a refill cycle, right?
That's great.
He's been doing that for 12 years as well.
So part of the next question, sorry, Kevin, is why doesn't everybody do this? Well, it's scary as hell. And this didn't happen overnight.
Right.
It grew organically.
So one thing, or actually, if you don't mind, Kevin, I'm just because I think it's relevant right here, is I've been going back to my very first position as a pharmacist, where it was a chain pharmacy, but it was a not so busy pharmacy, and we didn't have a ton of technicians. And I feel like I was the pharmacist first because I was the one taking in, I was the one filling in, and like kind of thing. So in getting to really know those patients, it really was fun. Like you're saying, there was engagement and you were excited to help people. Later on, when I was switched to a much busier store, I don't think anyone really knew who I was necessarily. When I at that first store, pregnant with my first child, it was like everyone was guessing what I was having, and I was getting gifts after I had my daughter. At the other store, I don't think anyone even knew I was pregnant. It was just like you're just behind there and just churning. So really interesting. And then the other thing that I love is the respect, if you will, and I'm not sure if that's the right word, but people respect that time and honor that time with the pharmacist. I remember so many times trying to counsel people, and like, I have ice cream melting in the car. Like, I don't have time to talk to you. And it would just shock me, like, okay, well, have that and make certain you take your statin that I'm handing you too, because you're going to need it. So it's really interesting that I think that this model that has been developed, or maybe the care model in general, is very different. And it's a definite culture, it seems to me. And I'm just like kind of comparing and contrasting here. And I'm really wowed by what I'm hearing and how it's still continuing after 30 years.
I was stunned to watch, why is this working? And then realized, let's face it. And you can see Chris is not in a hurry. He is as much of a gentleman as he appears on this screen right now. And, and he didn't have the numbers originally, but we have them now that, 3/4 of the prescriptions filled by community pharmacies are for chronic conditions. And some patients are not yet ready to fully share everything with us. And Chris is patient, and he employs really sophisticated motivational interviewing skills, and his team as well, to understand the motivation of the person sitting in front of them, even if it takes 10 years. That acute issues, when you've got a child with an earache, they act really quickly. That's a red basket. That happens. That goes out. The other things, he's there to be with them as long as it takes. And hey, Chris, I mean, you're the first pharmacist who ever told me, I heard you mention, would you let me be your pharmacist? Awesome. We say that for, lawyers and accountants. Why don't we do that with the person who is my pharmacist? He was the first one I ever heard that means relationship, and people believe it when he asks them.
Love that.
Wow. Yeah, I think some of the things you guys touched on are just really interesting to talk about this one point, Chris. So you made that transition, right? You went from being a dispensing pharmacy to being a pharmacy that's dispensing health, right? Dispensing prescriptions to dispensing and connecting as a clinician. During that kind of transformation, what were the biggest hurdles that you had to get over, Chris, to be able to get from one side of the equation to the other?
Probably workflow that happens. One, you need a commitment to do it. Once you have the commitment, then you can create these workarounds. Once you have the commitment to do something. So part of it was workflow, is how did the prescriptions come in? Where did they go? And if you're in an old style pharmacy and it's super busy and you're having trouble making a new workflow work, what do? You go back to the way that you were doing it. Everyone, human nature. So what we did is, and we noticed this too. So Kevin, when we had forms to fill out for the initial project, they were quite long and onerous. So we decided to change the forms. And each time we changed the form, it slowed us down. And we saw the numbers go down. And then after a month, they went back up again as we got better. So it really was workflow issues of how to do this new way of doing it, and having good quality people in your staff, and good trained pharmacy assistants. They are worth our weight in gold, and they're pharmacy assistants. They're not registered technicians, but a good quality pharmacy assistant. Honestly, the pharmacy assistants can run that whole pharmacy. You can go away for a week and that pharmacy will run because they've got the staff. They know exactly what they need to do. So
I'm going to close a blind, excuse me.
So creating those roles so that you can stay at the intake station. And don't forget, we made 1 million errors at the beginning. We corrected them as best we could. My documentation, I look back at the first documentation, you guys, I looked at it and I'm embarrassed. It was horrible, but it was new. So you know what? We had a commitment to see this through, and then we got better at it. Nobody hits the ground running 100%. And the nice thing is that some of the clients we've had, they can call us and say, this has been a horrible week. We just can't seem to move forward. And soon we're able to discuss and work through some of the issues, because I know we went through all of them. We made all the mistakes.
Mm-hmm.
Yeah.
Sure.
And, let's face it, now we've got an explosion of assessment and prescribing platforms that have come out in the last couple of years. And largely in Canada, for those of you who aren't aware, every Canadian pharmacist can now prescribe to one degree or another. And most can prescribe for at least, with the exception of one province, for at least a dozen or more common ailments. And then the scope goes all the way up to what I mentioned about Alberta, which is unrestricted prescribing. And that has been accompanied by some pretty sophisticated AI-supported documentation software that week over week is shortening the documentation time and improving the quality of it. Physicians are experiencing, you're seeing AI supporting physician documentation. The same thing is happening now with these tools. So the things that would take Chris and our team weeks and months, when we would be refining a report and then seeing the learning curve that he just mentioned, now those are electronic documents, they're AI supported, and they really are improving quickly. So it's just allowing more time for the pharmacist to just be a pharmacist, facing the person in front of you, listening, learning, doing what you were taught to do in school, even if you were taught in school a long time ago.
Yeah, I think that's the long time ago piece. I love that you ended with that, Jim, because I'm often curious to hear this. And I've heard it from several pharmacists saying one of the biggest things that holds us back is our unwillingness to change, because we're worried to go, you know what, checking these boxes, doing the adjudications, pushing things through the e-filing process. That's what I do now. Like I don't do the clinical thing. I don't talk to patients about their care. What's that done for you guys when it comes to hiring, staffing, selecting appropriate pharmacists, looking at the overall training regimen? How have you looked to curate that in your pharmacy staff?
Well, I think for us, we try to hire people that can think on their feet. Yes, if they have prior knowledge, fantastic. But honestly, people who can think on their feet, will train them. If we can't, we'll train them. Yes, it takes a long time. But if you treat them well, you pay them well, you've got staff that are willing to, in small communities, to stay with you for the life of their work, their work life there. They'll stay. And being part of the community. So Kevin, if you find people who are willing to be engaged, who are willing to learn, and we cross train all the positions. So we have a number of different areas within the pharmacy, blister packs. We have automated machines that need to be serviced. We have compounding. We do long-term care. All of those stations get rotated with the staff. They're all cross-trained, which means the staff are always learning something new. Okay. And if one person goes on holidays, we just have to move the Rubik's Cube, the pieces around, and the pieces are filled. So those are the type of things. So you have to work at it. But you'd be surprised at how effective staff, if you take the time and you said you treat them well, you pay them well, they just give it back in spades over and over and over again. Right from the pharmacy assistants to the register technicians, and even the front store staff have gotten into this as well, because they'll have somebody who will come in and say, hey, do you have some Tylenol for my little one? And they'll go and they'll show them the Tylenol, and they say, hey, would you like to talk to one of the pharmacists? Could I do that? Yeah, because none of the manuals for all of our kids that we had were very good, And I'm a pharmacist, and when I had my first little one, I still was worried about the dose. I triple checked it. So, so they come in and they actually triage for us. And, new moms that come in, boy, or new dads as well. It's like they come in and they're just they get out of that car and they're heading straight towards you because their little one is not well. And terrific, you're at an intake station, they can do that. So all of the staff have learned that if need be, funneling people into the pharmacy is what we want. And of course they come back, and part of the engagement is not just saying, well, here, take this, is educating the patient so that the next time they come in, they know what to look for themselves. Yes, that takes a little bit longer, but then again, hey, that frees up your time for the next new person who's walked through the door and looks around and says, wow, this is different.
So let me ask you guys a question related to that then. You posed the question yourself, Kevin, about whether it relates or whether there's something in Canada that might be different with employers and payers and whatnot. If you could pay $30 an hour to spend half a day every day checking final prescriptions, or $60 an hour, which would you prefer?
If I could make $60 or $30 an hour,
no. If you could, as the employer, or payer, if you could pay $30 an hour to check your final prescriptions, or you could pay $60 an hour to check your final prescriptions, which would you choose as the employer?
Yeah, I think the long story short on that one is if I'm the employer only looking at a fee-for-service model, right, not the value that may come out of it, I'm going to pay the absolute least I can to be able to increase my margins as much as possible. Right?
Well, and even what value I had this, and by the way, I just want to correct one thing that was mentioned in the introduction. That 20,000 pharmacists that picked up things last year was actually in Brazil, and I had I was schooled by the CEO of the largest chain in Brazil, who sort of said, I just don't understand you people in the Northern Hemisphere, because you have these large bottles coming in the back door, and then you recount everything, and small bottles going out the front door. So as far as I can tell, and Chris will laugh at this too. His daughter-in-law is from Brazil, and we've had this conversation as well. He said, as far as I can tell, the only thing that you're able to do is miscount them or contaminate them with dirty fingers. Why do you people do that? So what value is added in the handling of pills? Answer, zero. So why would you pay twice as much to have your most skilled and expensive talent doing something that doesn't require a pharmacist's license to do it? So
well, Jim, I'll answer that because we've done it for years and we're going to continue to do it until somebody says something different.
Yeah, I got to be able to count by fives. I mean, that skill set is valuable.
If you did nothing else differently and you said, I could, if it's half your day, and it's at least that in many pharmacies, that's 5 hours. If that's 4 hours a day, what would you do with the 4 hours? That's the question Chris asks in the boot camps and other things that we do with clinicians. His first question for them is, if I gave you 4 hours a day, what would you do with the time? And Chris, have you ever encountered a pharmacist who didn't know what she or he would do with the extra 4 hours a day?
Well, some of the older pharmacists, if you remember, Jim, were so much on send that they had a hard time talking to patients to find out, what the issues were. Again, old-time pharmacists, this is the way we're trained. You fill the prescription, you give them the 32-second spiel on amoxicillin, and they're out the door. And then you're on to the next one.
On that same vein, I have to ask this question because it's fun to ask it from the other seat. We often talk about the AMA, right, in the US, and talking about provider and or clinician creep, scope creep, right? The opposite is starting to trickle into some circles when it comes to what are we letting happen when it comes to our pharmacy technicians and pharmacy assistants taking on roles that previously pharmacists were leveraged inside of, right? It really speaks to what you were just saying there, Chris, when it comes to that push send kind of mentality. What are your guys' thoughts there when it comes to how do we evolve the healthcare system to fully leverage technicians and assistants, and at the same time recognize that pharmacists also have to evolve into a new space? How do we balance those things back and forth? Do you feel like there is a balance, or do we just need to move because the rest of the system is going, if we like it or not?
Well, when I graduated, there were no huge change, Kevin. There wasn't. There was a lot of small community pharmacies owned by a pharmacist, whether that was a male or female. They owned the pharmacy. It was small. They sold gift cards, or they sold giftware. They sold Hallmark cards and all of that sort of stuff. So each of them had their own prescription volume, which was, as Donna was saying at that first place you worked at, Donna, you did everything. And you talked to the patients, and you were there. You were that community pharmacist that everyone, if you would have stayed, had gotten to know you, and you would have saw the little kids when you went in there. You would have saw them having kids as well and bringing their kids in to see you because, hey, you're Donna. You've been there a long time. You're part of the community. So the idea of the assistants and the technicians really started to grow as pharmacies became, well, all of a sudden there was a big corporate, and of course corporate had much lower dispensing fees, and originally that was, that took a lot of business away from small community pharmacies. But as our community pharmacies grew, then what grew as well is the support staff around them, Kevin, as you were saying, the pharmacy assistants. And it was relatively recently that the pharmacy technicians were able to come and do those final checks. So what the real hard part is the reluctance of pharmacists to let go of the ropes and let somebody else do those technical things of filling the prescription. Pharmacists have a hard time letting that go. And why?
We're one generation removed from the same thing happening to nurse practitioners and midwives, right? And so as we now look at this, a couple of websites that might be interesting. There was a national study done in Canada that can be found at ourcare.ca that looked at primary care reform with a global lens. So we're seeing major primary care reform happening in the US, in the UK, and Australia, and elsewhere. It led to another website that I'll mention, which is teamprimarycare.ca, that is actually led by the College of Family Physicians of Canada. So this is the physicians realizing we need interprofessional collaboration in order for this to work. So rather than overlapping or supplanting any one of the primary care professions, let's remember social workers, therapists, dietitians, occupational therapists, and all of the other people who should appropriately be connected to each patient based on that patient's needs, right? Not based on provider-led anything. It's patient-centered rather than provider-led. I think what you'll see there is a really good appraisal of sort of the best available information in the world from Sweden, from elsewhere, that puts it in a patient-based context so that we can evolve according to the needs of that patient. And in some cases, that registered technician is the person who knows and is trusted most by that patient. And in some cases, will have the engagement and provide advice to the pharmacist, just as the pharmacist is often better known to the patient than the nurse practitioner or the physician. Or, Kevin, you practice in rural, remote, and indigenous medicine as well. We have a growing area there. Here, there's a new organization in Canada called the Indigenous Pharmacist Professionals of Canada. It's only a year old, but it is pharmacy professionals who are engaging in bringing in elders and knowledge keepers that make that a complementary approach. For some patients, that's going to be really essential, right? And so if we make it patient-centered, we don't have to worry about the turf of the pharmacist or the physician, and we don't have to think about encroachment. I'll give one other suggestion for anybody who wants to look into it. There's an organization in Canada called the Canadian Association of Pharmacy Technicians, or CAPT, who are engaging with all of the professions there to evolve and standardize that practice, since in many cases, the registered pharmacy technicians do more than the things that fit within or their registered scope. They often end up being the operational leaders of, especially of busy pharmacies. They have ambitions and goals for leadership and whatnot, and that further reduces the burden on, if you will, the pharmacist as surgeon. What we still look like is the surgeon, or Chris's profession is like the surgeon who is still mopping blood off the floor and washing their own instruments. Well, ISO 9000 and Six Sigma got rid of that in hospital practice 35 years ago. But pharmacists are still mopping blood off their floor figuratively. And we can now have these better practices.
It's amazing.
Yeah, I really appreciate it. I think it's really difficult for me to play devil's advocate against this model. Like, it's just something that I feel so passionately about that has to change. Jim knows a lot of my work has been toward trying to encourage the pharmacy profession to recognize there are massive opportunities, right, in the fee-for-service space, in the value-based space, in the cash paying space, of leveraging your skill sets and moving toward these cognitive service deliveries. The other piece is we can't hold our technicians and our assistants back. They're rock stars. Like, they're owning this space, and they should, right, in many ways, shapes, and forms. And we're going to continue seeing legislation allowing them to do more and more and more. And therefore, as a pharmacy profession, to still provide value to patients in general, speaking with my patient hat on here, I want to talk to the expert, right? I want to talk to the drug expert when I go in. I don't want to have a transactional relationship any longer.
Well said.
Yeah.
I think that's one thing that's held us back for a really long time. And I love that you've taken it on, Chris, and really recognized it from a deep roots standpoint. Is we have had that transactional relationship with patients and communities for so long that it makes it a difficult journey, and maybe a long journey, to get folks to think about coming to the pharmacy as a different experience.
Yes.
And I really hope that we can recognize that we do have models already inside the United States that are doing these kinds of things. oftentimes the models inside the US that are doing these types of things are free of any insurance burden, like the VA and IHS, right? That are leveraging pharmacists in this type of way, similar to what Chris and Jim are doing in Canada. We just have to find a way to make all the financial dots align. And maybe that's a little bit of heartache and documentation that Jim's AI can be able to take care of there.
Yeah.
Hey,
For
you know,
sure.
in Donna's hometown, you've got a really famous guy who ran a football team for a long time, and who is really famous for a 3-word phrase, and it really fits in what Chris redesigned. You remember the 3 words, Donna?
Do your job.
Right. And so what Chris
Wear
did,
no sleeves.
Sorry, and no sleeves. Yeah,
wear
and you
no
need a hoodie. But you know, essentially what Chris said
I
is,
have the shirt.
do you have the shirt?
I do. When he retired, I got the shirt.
So even foreign devils like us know what Mr. Belichick had to say to the team. And essentially what Chris then said was, pharmacists, your job no longer includes data entry, adjudication, dispensing, compounding, checking, or inventory management. That's not your job. I want you to do your job and let this well-trained team do theirs.
Yeah.
Do your job.
Love it.
I love it. Well, Chris and Jim, this flew by in terms of time. So thank you guys both for your time here. Any parting words for our audience?
Oh boy. So one, if people are thinking about it, just it's a win for the pharmacist. Your level of job satisfaction goes way up because you make such a difference in people's lives. It's a win for the patient. They crave this sort of stuff. Just because they don't know that it's out there doesn't mean they don't crave it when they experience it for the first time. Okay. Believe me, nothing gets filled right away at our pharmacy. It takes time. And if you educate the patients, no big deal. Can you come back on Tuesday for that? Yeah, sure. No problem. We don't have to be a fast food outlet, but patients, they crave the time and they crave the attention and they love the information and they get, because it's their health and they love that. It's great for the pharmacy owners because honestly, it's pharmacy owners that have to take some of this burden to make the change. If the pharmacy owners say, hey, crew, let's change and let's start doing something a little different, it's under their, direction that they have to make all of these changes. And there's lots of little things that can hold it all up. Believe me, there's so many things that can hold up the change. And lastly, it's a change for us with the way we have medicine in Canada. It's a real bonus for the health system in Canada because you are saving so many dollars by providing better care right up front. It's just such a win. I would love to talk about each one of those wins because I live those every single day, and I'd love to share that.
Awesome. Jim?
I would, he's my brother. I love everything he says. Like he said, I would simply reinforce that notion that, and would you mind being cash flow positive on day one, and you don't need anyone's permission?
I don't think those bells can ring any louder right there. Nobody's permission to be able to do your job and leverage your license and take care of your community. I think those are all massive positives for sure. Donna, last word?
I'm wearing my t-shirt tomorrow.
Okay, fantastic. I'll watch.
But no, and I do think that it's so important. I just see that there is, in some areas, a lot of areas, cultural shift and different mindset is really a push that will have to happen in order for this to become mainstream here in the United States, especially in, some areas. I'm thinking like New England, where everything's like quick, fast, and, hustle bustle kind of thing. But I want that change for people. So I hope to encourage it. Thank you.
worth every bit of it. Once again, thank you, gentlemen, so much for sharing a little bit of that model and encouraging, I think, the pharmacy world and patients to expect that, right? I mean, that's one thing that you guys mentioned, that patients now expect that from your pharmacy. And I think that that expectation just sets them up for, one, empowerment, and two, just a better health trajectory overall with having a pharmacy partner like that. So once again, thank you guys so much. Really excited, all you listeners that were tuning in. Really appreciate all you guys. Check us out next time and next week on the Med List. Talk to you soon.
Donna.